First of all, I would like to thank you, Professor Jean-François Guillon, that invited me to make this presentation. Our presentation is on total extraperitoneal versus Liechtenstein hernioplasty, a systematic review by conventional updated meta-analysis versus cumulative meta-analysis on the determination of clinical efficacy and harm. The cumulative meta-analysis, based on different mathematical backgrounds compared to conventional updated meta-analysis, can pinpoint the first time or the turning point when a difference in the outcome occurred between the treatment and control cohorts, and consequently to study trends in good and bad effects. The quintessence and essential of difference between the conventional updated and cumulative meta-analysis were demonstrated by Lau and al. In landmark article, Cumulative Meta-Analysis on Therapeutic Trials for Myocardial Infarction. This study includes 33 randomized controlled trials that conducted between 1959 and 1988 for 30 years. There is special attention we should focus on the study in 1973. In the study Frankfurt 2 demonstrates for the first time statistically significant results in cumulative meta-analysis compared to non-significant results of conventional meta-analysis. From 1973 until 1988, all the following studies demonstrate significant results in cumulative meta-analysis compared to non-significant results of the meta-analysis. Until 1973, the results are produced by 8 studies, including 2,432 patients, and we have also to pinpoint here 2 studies that demonstrate on both methods of meta-analysis significant results. These studies are the Gruppo Italiano per lo studio della streptochinasi nell'infarto miocardico and the study Second International Study of Infarct Survival, ISIS-2. These studies had the common hallmark that they were well-powered, including 11,412 and 70,887 patients, respectively. Reflecting on the above results, we can formulate the following questions. Do we need to perform more trials supported by big budget and long periods of hard work when, for the 13 consecutive years, the cumulative meta-analysis demonstrated statistically significant results compared to non-significant results of the conventional updated meta-analysis? In nutshells, the cumulative meta-analysis can determine clinical efficacy, harm, and turning points of the accumulation of evidence over time, and may help make recommendations for treatments, healthcare policies, and designing future results. In September 2019, Gavrielidis and al. Published a study on TEP versus Liechtenstein procedure. They demonstrated that the recurrence rate was significantly higher in the results of cumulative meta-analysis compared to non-significant results in conventional updated meta-analysis. In particular, this period starts when the study by Neumeyer et al. Added to the existing evidence, and consequently 10 more RCTs from 2004 to 2019, although they demonstrated non-significant results in the conventional updated meta-analysis, in the cumulative meta-analysis, all of them demonstrated statistically significant differences. Of note, the high quality RCT published by Goodlich and al. In 2019 also demonstrates the same results and did not have any impact on the established evidence. Consequently, Kekerling and Adolf interested on our results and formulated the following essential comments. Firstly, that the studies by Neumeyer et al. And they dominated the results because of their large sample size and the high rate of recurrences. Secondly, the high rate of recurrences may be due to the use of mesh size other than the standard size, then by 15 centimeters, as recommended by the guidelines. Thirdly, the study by Eklund and al. Had a problem with a single surgeon responsible for 33% of all recurrences, and at the end, a Bayesian network meta-analysis published by Olfi et al. Demonstrated comparable recurrences rates between the two procedures. Our response was titled "Numbers Speak Louder and Communicate a Clearer Message Than Words," and based on the following answers. First of all the previous meta-analysis and the present meta-analysis by Gavrielidis et al. Demonstrates significantly higher recurrence rate for the TEP compared to Liechtenstein procedure. In the study by Eklund et al., even after exclusion of a single surgeon, the recurrence rate in the TEP cohort was still twice as high as in the Liechtenstein cohort. The study by Neumeyer et al. Points the beginning of the time periods of 15 years, where 10 more studies, including 4,848 patients, demonstrated significantly higher recurrence rates in the cumulative meta-analysis compared to traditional updated meta-analysis. In a nutshell, it is not only the study by Neumeyer et al. That demonstrates statistically significant results in cumulative meta-analysis compared to conventional updated meta-analysis. Another interesting point is that the selection criteria, the inclusion criteria by Olfi et al. Were very selective. A systematic share of the literature demonstrated that 90 more randomized controlled trials could have been included in the study by Olfi et al. Another point that we expressed is that the high quality RCT by Goodlich and al. Did not modify the already established evidence for significantly lower recurrence rate in Liechtenstein cohort. Notably, Rosenberg J. and Andresen K. wrote a letter to editor titled "Wrong Conclusion in Meta-Analysis." Although that the title of our article indicated that the study was a systematic review by updated traditional and cumulative meta-analysis of randomized controlled trials, Rosenberg J. and Andresen K. based their conclusion only on the updated traditional meta-analysis and disregarded that our study aims to compare the two methods, and those concluded that the message of our analysis was wrong. Our reply, titled "Analyzing Topics Using Different Methods Promotes Constructive Debate." There we repeated actually our answers from our previous response letter. Numbers speak louder and communicate clearer message than words. And moreover, we proposed a multi-center meta-analysis to be based on the following principles. First, predefined outcome estimation. Second, size of hernial defect, size of mesh use. Fourth, evaluation of cost effectiveness. And at the end, to take into account the experience of the operators. At the end, Klinger reflected on the original and subsequent letters and responses to make things right, and wrote a letter to the editor based on the following 8 essential comments. First, in some hands, TEP as well as Liechtenstein can be performed without any recurrence and pain. Second, anatomy, biology, immunology, sufficient mesh overlap and learning curve may reflect the development of recurrence. Thirdly, probably only 20% of recurrences cannot be related to individual risk. Fourth, how many of patients were free of extra procedural risk? Fifth, what level of difference justifies abandoning a procedure? Sixth, though a mean risk profile of the standardized cohort can be calculated, this does not reflect the individual risk. Seven, the main question should not be which technique is superior in general, but in which patients TEP or Liechtenstein is better. Eighth, randomized controlled trials commonly do not allow analysis of subgroups with sufficient power. Thank you for your attention, and I'm happy to answer any of your questions. Full stop.